Hi all. This month's case gas comes to us from Grand Prairie. Thanks to Mark Woods for bringing this to my attention. So we have this 65-year-old female. She was admitted for a week with respiratory problems. She has a history of COPD and possible opiate misuse. Today she doesn't look as well as this photo. Star 5 was dispatched for an IFT, interfacility transfer, to bring the patient back to Grand Prairie as she's gotten much worse from a respiratory and level of consciousness point of view today. And the working diagnosis is a COPD exacerbation. Here are the initial vitals on Star 5 arrival. You'll note that end tidal is included there. This was a non-invasive end tidal CO2 detector. You can gain a lot of information knowing the end tidal. And you know, we've got this video here explaining why this end tidal should probably be our 6th vital sign. If SpO2 is our 5th, end tidal should be our 6th. So feel free to watch this video for a reminder on the physiology behind that. So as Star 5, when Star 5 arrived, the sending site was preparing for intubation. The AMCs subsequently performed this task, and with first pass success. I'd like to discuss the indications for intubation in this case. For that, let's see if this link's going to work. Yeah, I think it is. So we've got our CCMCPs, our AHS, EMS, CCMCPs, and under the Airway Universal, the link for the notes part of the Airway Universal is right here. And so let's pull this up and let's go there. And I'll just make this as big as I can. If we go through our indications for intubation, does this patient have a patent airway? Well, yes, they do. There's no physical obstruction. This patient does have a patent airway, so we don't have an indication there. Airway protection. This patient, and when we're talking about that, we're talking about protecting the airway against aspiration of anything other than air into the trachea. So typically that's things like vomit and blood and secretions and foreign bodies. This patient's GCS was 6, so low. We'd have to be at least concerned. GCS we know isn't a great, there isn't a, yes, GCS 8, intubate, that's a bit of historical thinking. There isn't an absolute number when patients lose their ability to protect their airway against aspiration. So more specific things would be things like loss of their cough reflex, loss of their swallowing reflex. So if you looked in their mouth and they were supine and they had a bunch of secretions that they had not swallowed, then that may be an indicator that they've lost some of those airway protective reflexes. But certainly a low GCS and a declining GCS would certainly raise our concern that they may not be able to protect their airway, and that is the case in this patient. And then finally, respiratory failure. This patient's SATs were 100%, as you saw in the last vital signs slide. So that was with some supplemental O2, but as you can see, the indication is hypoxemic or hypercarbic or both respiratory failure not resolved with less invasive means. So we put the patient on some supplemental O2, which is some less invasive means, and we resolved their hypoxemic respiratory failure. However, this patient's end tidal CO2 was 107 on Star 5 arrival. And we know that is the lowest value for the CO2. So the arterial CO2 is going to be somewhat higher than that. And, combined with the patient's decreased LOC, hypercarbia is certainly a strong possibility in this patient. And hypercarbic respiratory failure not resolved with less invasive means is an indication for intubation. Now, I will say, often non-invasive ventilation is effective in these patients. This was tried prior to Star 5 arrival, and the patient was nearly apneic, so it didn't work. So the decision made to proceed with intubation. So again, in this patient, we have 2 of our 3 primary indications. We've got an issue with probable airway protection or loss of airway protection, and we've got hypercarbic respiratory failure. So we'll just close out of this, come back to the presentation. We will move to the next slide. So, as I said, first pass success, Star 5 AMC intubated this patient successfully, and now we've got to place this patient on the mechanical ventilator. And so here is our CCMCP, and they chose the obstructive lung, I think quite appropriately, the obstructive lung CCMCP. We know what those settings are, but for those of you who are not as familiar with the CCMCPs, you can just take this link that's here. Lost my cursor, my apologies. Gotta find my cursor. So you can just take this link here and that will take you to the obstructive lung mechanical ventilation CCMCP. This was the waveform that Star 5 were presented with. More on this in a bit. We are going to now proceed through the blood gas interpretation. But interestingly, we're going to do this because further practice, more reps on interpreting blood gases, but we'll see at the end of this video why in this particular case the sort of compensation part of the blood gas interpretation probably isn't all that important, but let's proceed. So here is the blood gas. So this was a venous sample. This was the first gas taken post intubation. There are the values. So let's interpret this gas. We're going to use the STARS 4-step approach. It is important when interpreting a gas, a venous gas, that we do know the end tidal. And the end tidal at this point in time, when this gas was drawn, and this is from the patient care record, was 82. All right, so we're going to use this document. This is our one-pager, and remember we've got a pocket version. And for those of you who aren't STARS AMC, feel free to obviously take a screenshot of this. This is what you're going to need to interpret this blood gas. And I can tell you, you don't need to remember the formulas. You need to know how to apply this document. But having access to this document and knowing how to apply it will allow you to interpret the blood gas. So here's the 4-step interpretation right here. So let's go through this. pH. What is our pH? It's acidemic, right? 7.09. That is acidemic, and again, emia refers to anything in the blood. And that's why we use the term acidemia when referring to the pH, because it's a marker of the pH of the blood. What is the process, the primary disorder that is causing this? And the reason we do step 2 is to get us on the right row for this top document here. The primary disorder, that is this column. And that will get us in the appropriate compensation row so we can work with this document. So acidemia, which explains it? Does the CO2 explain the acidemia, or does the bicarb explain the acidemia? Well, the bicarb is higher than normal. So the bicarb would not explain the deviation in the pH. The only value of those two that explain the deviation in the pH is the CO2, which is extremely elevated. So the process causing the acidemia is a respiratory acidosis. Step 3 is calculating an anion gap. We don't need to do that when we have a respiratory acidosis. So step 4 is compensation. So let's work out compensation. So here's our gas again with our end tidal. Here are our compensation formulas and our normal values. We know that we're on the respiratory acidosis row from step 2 on the previous slide. And so for that we have 2. We have an acute and chronic. So let's walk through this. The compensation formulas are based on arterial values. We know from bracketing, and if you need a little refresher on bracketing, here's the YouTube video on bracketing. But we know from bracketing that the end tidal CO2 value is the lowest, so in this case that's 82. Next up is the arterial value, and the highest of the CO2 values is the venous value. In this case it's 124.1. So we know the arterial CO2 is going to fall somewhere between 82 and 124. So the formula we're going to use, we're going to calculate, we don't know, like we have some idea from the history that, this patient probably has a chronic respiratory acidosis. She may have a chronic respiratory acidosis. Looking at her previous medical records would help with this. But she does have this known diagnosis of COPD and has been admitted for a week with that. But she acutely got worse today. So let's just work out the formulas for both. And I typically do this when I interpret a blood gas for respiratory acidosis. I'll work out the numbers for acute and chronic. So if we work out for acute, and we know the acute is a process that's only been going on for a few hours. And after that few hours, we start to get more compensation with bicarb that is fully compensated somewhere around 5 days. So a stable patient with COPD, if they've been in their stable state for greater than 5 days, they will likely be fully compensated from a bicarb point of view with respect to their respiratory acidosis. So for an acute process though, the change in bicarb should be 0.1 times the change in the arterial CO2 from normal. Remember, it's the change from normal. Our numbers are, if we look at the low end of the scale, it's going to be 83. If we come over here, we know the lowest value that the arterial CO2 could be is 83 based on our bracketing. So a normal CO2, arterial CO2 is right here, it's 40. So 83 minus 40, so we're going to go 0.1 times 83 minus 40. 0.1 times 43 equals 4.3. So the delta bicarb is equal to 4.3. So the final bicarb, the arterial bicarb, should be 24. That's your normal arterial bicarb level right there, plus the 4.3 that we should see in compensation, and our bicarb should be 28.3 if this were purely an acute respiratory problem. The actual bicarb, the actual venous bicarb is 38. We know that there is better correlation between arterial and venous values for bicarb than there is for CO2. And the arterial value for bicarb is slightly less than the venous value for bicarb typically. So we're going to say, and we see this in the compensation, the typical is 25 for venous, 24. So we're going to take one away from that to give us an arterial bicarb of 37. Okay, if the patient was compensating appropriately, they should have an arterial bicarb of 28.3. In fact, this patient's arterial bicarb is 37. More on that in a minute. Let's work out the other end of the scale. So the other end of the scale up here. So the highest the arterial value for the CO2 in this case could be is 123. We know the end tidal is 82, so the lowest is going to be 83. And the venous is 124 right here. So the highest arterial value for this patient is 123. So let's do some math there. So now the delta bicarb, if we assume they're at the high end of that scale or that bracketing, is 123 minus the normal arterial CO2 value is 40. So it's 0.1 times 83. That means the change in bicarb is 8.3 if the actual arterial CO2 is up to 123. So 24 plus 8.3, the arterial bicarb should be 32.3. So this gives us a range arterial bicarb. If the process is all acute, the arterial bicarb, and there was appropriate compensation, the arterial bicarb should lie in the range of what we calculated on the previous slide, 28.3 to 32.3. And in fact, we know the arterial bicarb is 37. So is there a second disturbance in this case? Just give you a moment to think about that. Yes, there is. Because the actual arterial bicarb is 37, and if there was pure, if compensation was totally appropriate, it should be lower, between 28.3 and 32.3. So the actual arterial bicarb is higher than what it should be if it was just compensating appropriately. So therefore, there is a second disturbance, and that is a metabolic alkalosis. Again, because the actual bicarb is higher than what we predict from our compensation formula. So we might spend some brain power looking for other causes here. I don't think it's important in this particular case. We'll talk about why. But looking for causes of a metabolic alkalosis, and we've got a differential diagnosis around that. So let's do some math if the process were all chronic. Okay, same bracketing. We know the patient's arterial CO2 right now at this moment is going to be somewhere between 82 and 124. Let's work out what it should be if the process were all chronic. So if the process were all chronic, the change in bicarb changes much more. It changes by a factor of 0.45 times the change in the arterial CO2. So let's work the low end of the scale first. Let's assume the patient's arterial CO2 is 83. 83 minus the normal value for CO2 of 40 leaves us with 43. 0.45 times 43 is 19.3. That means if the process were purely chronic, the arterial bicarb should be 24, the normal value for arterial bicarb, plus the compensation we would expect at 19.3 equals 43.3. Okay? Again, this patient's actual arterial bicarb is currently estimated at 37. Let's work it out for the other end of the scale up here at 123. 123 minus 40 is 83. 0.45 times 83 is 37.3. We add that to the normal value for arterial bicarb, and that gives us a value of 61.3. So depending on what the patient's actual arterial CO2 is, their bicarb should range somewhere between 43.3, which is the number we just calculated on the previous slide, and 61.3. But we know their actual bicarb, arterial bicarb, currently right now is 37. So is there a second disturbance in this case? Yes, there is. If the process were all purely chronic, that patient, because the actual bicarb is lower than what our compensation compensation calculations predicted should be, then this patient has a second disturbance that is a metabolic acidosis. Of course, we got a differential diagnosis for that. So we would look at that and expand our differential, or look into other causes of that second disturbance. But again, I'm going to talk about why that's probably not important in this case. We just worked it out. If the respiratory process was purely acute, the arterial bicarb should be in the range of 28.3 to 32.3. If the process was purely chronic, the arterial bicarb should be in the range of 43.3 to 61.3. We know that the arterial bicarb, based on this right here, is about 37. So it's kind of falling between those two ranges, those two values. And I think there's a reasonable explanation for that. This patient, again, likely has a chronic component to their respiratory acidosis, but then has a superimposed acute component that started sometime today. And so they're evolving potentially between this chronic to this acute, and if this acute process persisted, we would expect that their bicarb would continue climbing and get up in this range eventually after another 4 or 5 days. So that was a lot of math, right? That was a lot of math. I think it's important, again, to not so much in this case, and we'll see why in the next 2 slides, but blood gas interpretation really allows us to get a little more targeted with our differential diagnosis and potentially potentially improve the care we can provide for our patients. But let's talk about why this maybe isn't important in this case. Here are the waveforms that we got, that star 5 got in this case. The COPD is resulting in increased resistance, and we can see that in these waveforms. So what they did first, what star 5 did first, is they put this patient on SCMV+, which is our PRVC mode, and got 80 mils of volume, only 80 mils of VTE. So they quickly pivoted and changed to PCV+, which is a pure pressure controlled mode. They started with a P control of 25, so that P peak in the top left corner there, up over here, at that time was 30. Because remember, the peak is the sum of the P control and the PEEP. And so they got more volume than 80, but still not enough. So they continued to titrate up on their P peak to attain more volume. And you can see at this current moment in time when this screenshot was taken, their P peak was 39 centimeters of water, and they were getting 451 mils of tidal volume. All the while they were doing this, they were watching their plateau pressure and calculating their plateau pressure, and it was 22 centimeters of water, significantly below the 39 centimeters of water that we see as the peak pressure. We know from these waveforms, look at the flow waveform, the second one, and there is flow present. This inflection point right here marks the end of the I time. There is still flow present, quite a significant amount of flow, like 30 liters per minute of flow, still present at the end of the inspiratory time. You can only have flow if you have differences in pressure. If their pressures between 2 points are identical, you cannot have flow between those 2 points. And so we still have this situation where we have this peak pressure. The plateau pressure has not caught up to that peak pressure. There's still lots of flow at the end of the I time. So we know that that plateau pressure is significantly less than the peak pressure. The other interesting thing we see on this waveform is the really significant, and so, sorry, this would be an image showing that there is inspiratory resistance, which we would expect in this patient. There's also expiratory resistance. Look how long it's taking this patient to exhale. We have a very slow rate. Our typical rate for the obstructive protocol of 10. And over this time period of 4.5 seconds, this patient maybe hasn't even fully exhaled at the end of, you're very close. So lots of expiratory resistance in this. So these things are what is important in this case. Remember what our goals of mechanical ventilation are. Our goals of mechanical ventilation, okay, what's the first one? Adequate oxygenation. That's marked by SpO2 and delivery. You can have all the SATs you want. You can have SATs of 100%. If you have no blood pressure, then there is no, that hemoglobin is not being carried to the tissues where it's required. So it's SATs plus hemodynamics. Adequate ventilation. Remember, ventilation is not just minute ventilation, that's part of it, but it's also Q. Q is your pulmonary perfusion. You can have all the minute ventilation you want. You can have a rate of 40 and tidal volumes of 1 liter. If you have no Q, no pulmonary perfusion, you're not going to ventilate out any of that CO2. And finally, the goal is prevention of further injury. And this generally relates to our lung pressures, our intrathoracic pressures. Both of these things, lung injury and hemodynamics, are made worse potentially by higher pressures. Okay, that's what we need to be focusing on in this case. Not necessarily the math around what the compensation formulas predict the CO2 should be and what they actually are, because we know that when we increase minute ventilation, we can cause further injury. We can impair hemodynamics. We can cause lung injury. Okay, so we're going to just go through this again with some animations here. So again, the crew switched to PCV plus. We talked about how there was still flow present at the end of the I time, which means that the plateau pressure is less than the peak, and you can use this information to guide how much you can continue to increase your peak pressure as long as your plateau pressure stays within a safe limit. We have a bit of a magic number for a plateau pressure of 30. But remember, the lower the plateau pressure, while still accomplishing adequate volumes, adequate oxygenation, adequate ventilation, the better. And then we talked about the expiratory flow waveform on this as well. But I think importantly, again, remember the goals. Okay, remember the goals. The CO2 in this case doesn't matter that much. It's certainly not as important as adequate oxygenation. Oxygenation being SATs, the SATs in this case were never lower than 99%, and you can see the FiO2 is down to 65. The crew was titrating down on their FiO2 the whole time. The other half of oxygenation is delivering that oxygen to the tissues. So oxygenation is the #1 goal. And trying to blow down CO2, if we get too aggressive, we can impair the delivery part of oxygenation. So all things being equal, absolutely. If we're not getting any auto PEEP, if our pressures are low, our lung pressures are low, and if we've got really good hemodynamics, absolutely. And maybe the pre-hospital treatment of that obstructive pathology will start to work, and we'll be able to we'll see some less obstructive pathology, and you'll be able to safely increase the minute ventilation and blow down that CO2, and that's fine. But if you find you're getting into trouble with hemodynamics or higher pressures, don't worry too much about the CO2. This process that is causing this problem in this patient often takes days to reverse in the ICU. You will usually not be able to reverse it in our pre-hospital environment. Okay, so that's it. So again, good review of blood gases and in their interpretation. And then I think a good discussion around why in this particular case, maybe not that important. And this screen that is in front of you and the patient's hemodynamics, so your other monitor that you have showing the vital signs are what is important. And with that, I'll leave it, and thanks very much.